Hello and welcome to this presentation on physiotherapy problem lists. So for a little bit of context, if you've happened to stumble across this video randomly, I'm currently on a teaching placement as part of my third year studies at Melbourne University. And this is just to help the first years sort of wrap their heads around problem lists, particularly for neurological physiotherapy, as that always seems to be one that takes a little bit of time. Even though I'm going to be using the template for our neuro core subject, which is this here, you can definitely use the same steps and thought processes for MUSC, and I'll actually be using some MUSC examples as we go through just to demonstrate that. So if you're unfamiliar with the template, we've got our functional problem up the top left, our observations, our hypothesized contributing factors, our assessments for those HCFs, and then our confirmed contributing factors. And then down the bottom, we've got our goals, which we divide into short and long term. So our first step is to identify our functional problem. So most often this is the reason or reasons why the patient has come to see or been referred to see a physiotherapist. This should always be task or activity centered, definitely for neuro. So even when pain is present, it's often that they'll come to see someone because the pain's stopping them from doing an activity. So even though the pain's there, that's probably not their number one problem. It's going to be whatever the pain is stopping them from doing. So for example, someone might come in with a sore ankle, but their functional problem is going to be unable to participate in sport or something like that. So another way to think of this is, how would the patient, their friends, family, or carer describe the problem? So it might be in neuro, for example, you might have someone with a brain injury that can't actually communicate what their issue is, but their parent or their carer might come to you and say, look, he's really struggling to get up the stairs. He looks really balanced and uncoordinated. And that would give you a good idea of what the problem is. So typically in neuro, we watch the video of someone doing an activity and then develop our functional problem. However, it's definitely possible to get this from just a subjective assessment. So as I mentioned before, if they're telling you they're having trouble getting up and down stairs, think back to MUSC when you're talking to the patient about what the problem is. Really common example and really often used example is that in MUSC we get our functional problem from the subjective before we've done any observation or physical examination. So with observations, what we're doing is asking ourselves, what do I see that explains the patient's functional problem? So the easiest way to do this, and what we do in neuro, is to have the patient perform the task or activity that they're having difficulty with. Now in MUSC, it can get a little bit tricky, and in theory neuro as well, if it's time dependent. So for example, someone might say, I'm training for a marathon, and at the 20-kilometer mark, they've been running for an hour and a half, my Achilles really hurts. Now, obviously in clinic, we can't have them run for an hour and a half unless you tell them before they come in, can you please run for an hour and a half? So what you might have to do, and what you will have to do, is find other ways to load the tissue a little bit more quickly to try and bring about whatever problem that they're having. So while we're observing, we're looking for any deviations from what we would consider typical for performing that activity. Context is really important here, because obviously if you took a 5-year-old, a 25-year-old, and an 85-year-old, how we would expect them to move would be vastly different. So if you're assessing a 5-year-old, there's no use considering what's typical for a 25-year-old, because you're going to find a bunch of deviations that may actually be age appropriate and normal or typical for that age group. So always think back to whatever age and whatever demographic that you're dealing with. Really common early on is that you'll become fixated on the first deviation you see. To avoid doing this, I would always just start from the head or start from the feet and work his way down or up, go joint by joint, look from the front, look from the side, and look from the back, so we can consider all three planes of movement. Obviously transverse, you're gonna have to make some assumptions because we can't get a bird's eye view more often than not. And even if you do notice something really obvious, still go through the whole process because you might miss something else out. I've got here beware of red herrings, which sort of comes back to our deviations away from typical. So if it's appropriate, I'd like you to relay these back to the patient, because what you see might actually be normal for them. So if you've had someone who's 40 and when they were 5 years old, they were in a car crash, and had their ankle fused, you would expect that for the previous 35 years that they've had reduced dorsiflexion. Now, if they've only just had the pain or only just started having the problems, it's highly debatable how relevant that reduced dorsiflexion is going to be, even if it's something like running that sort of needs dorsiflexion. So you would still note this, but you'd probably just note that they've got reduced dorsiflexion, but you'd also note that this is actually normal for that patient. So on occasion as well, you might be able to get some observations from the subjective assessment. It sounds a little bit funny, but really obvious example that I can think of is if someone comes in and they're either MCL and or ACL deficient in their knee, it's likely they're going to be complaining about instability. So straight away, one of your hypothesized contributing factors is going to be there's instability at the knee before you've even looked at them moving. So with our hypothesized contributing factors, this is basically what impairments can possibly explain my observations. So I like to try and fit these into one of these 4 categories. The first one is range of motion. The second is motor control, strength, or stability. The third is coordination, balance, or I've got planning there, but I'm going to change that to cognition. And then the fourth is pain or fear avoidance. And I'm going to go through these in a little bit more detail now. So if you've observed that there's reduced range of motion, you need to start thinking about what's the cause of this. So range of motion is influenced by both contractile and non-contractile tissues. So it's important that you consider whether there's spasticity, a decrease in muscle length, or the presence of a contracture, whether there's an issue with the ligaments and this is what's causing it, whether there's any damage or changes to joint surfaces or articular cartilage. And then obviously pain can also limit range of motion. I don't like using pain as our primary cause, which I'll get into the last slides. Okay, so if you have hypothesized that motor control, strength, and or stability is a contributing factor to your observations, you need to ask yourself, what's the likely cause? So important to note that motor control and strength involve the full motor unit, which is the muscle tissue and the connecting neurons, as well as the central nervous system. So you're going to have to think about both of those. Example would be differentiating between, is this person's knee extension weak because they've got a torn quadricep, or is it weak because their brain can't tell their quads to turn on? And then with stability, this is created via a combination of motor control and strength, as well as ligamentous and joint stability. So we sort of think about active versus passive. So an example here would be, are they missing stability at the knee because their quads aren't strong enough to maintain extension? Or are their quads and hamstrings really strong, but they just don't have an ACL and MCL? So the second there's any lateral or anterior movement, that they become unstable. So if you think that coordination, balance, and or cognition is a contributing factor, again, what's the likely cause of this? Consider that coordination and balance involve a combination of both sensory input and motor output. Sensory input involves a number of systems such as sensation, proprioception, that should say visual, and vestibular. There are more than I've listed, but these are the ones you I've seen the most on placement, and I presume probably most likely to see when you're on placement. So with motor output, this involves both the peripheral and central nervous system, similar to the previous slide when we talked about motor control and strength. So you need to consider both of those. So a good example of a central nervous system causing issues with motor output would be ataxia, which is obviously pathologies of the cerebellum. Also, I think it's worth flagging the definition of cognition, mostly for the sake of making sure you avoid jumping to the conclusion that a patient's cognitively impaired when it may not actually be the case, as nothing says terrible patient rapport like implying they have an intellectual disability when they actually don't. So know that cognition is just memory, and not just, but primarily a memory and thinking issue. So if the patient understands what you're telling them to do, they remember what you're telling them to do, but they just can't do it, that's not impaired cognition. That's going to be sort of that motor output problem that we were talking about before. So one way you can sort of identify where in the steps the issue sits is by considering the steps of carrying out a motor function. So I'm going to use the example of shooting a basketball. Ideation would be the thought, I'm going to shoot the basketball into the hoop, which would be cognition. Planning is your brain going through the steps and processes of how you're going to shoot the ball using those sensory systems I mentioned earlier. Execution would be the physical act of shooting the basketball, which is primarily a motor output, but will still involve sensory input to make adjustments while you're actually taking the shot. While feedback is basically what it says on the tin, we use the information we gathered to compare our plan and execution so that when we shoot the basketball again, we can make adjustments and hopefully improve our performance. So this is probably the one that I find the most challenging to think of my hypothesized contributing factors, just because you can't really see whether the vestibular system's functioning, or you can't see like their brain ticking over while they're trying to do something, whereas you can see they don't have strength. So don't be too concerned if this one is a little bit tricky to start out with. It does get easier. So finally, if you think that pain and or fear avoidance behaviors are a contributing factor, what's the cause? So I don't like thinking of these by themselves. So alone, they don't explain the patient's functional problems. So if you do think pain and fear avoidance is contributing to what you're seeing, you need to go back to the previous three categories and sort of work out the underlying cause. Now, I don't know how far in the DPTs ones are, but you'll learn at some point that determining the underlying cause of pain can be difficult. So I suggest you use a biopsychosocial health model of health, as well as considering both peripheral and central drivers of pain. So both what is happening at the local tissue, as well as neuroplastic changes in the nervous system. So general tips I have is that initially it's easy for your thoughts to become disorganized. My tip here is to write down every idea that pops into your head. And then when you've run out of ideas, go back through each one of those ideas and place it into the table where it fits best on that problem list template. i.e., does it fit best as a functional problem, an observation, or a HCF? Or if for whatever reason you've thought of tests, then pop them in the test column. So once you've done this, then go through your list of observations that you've made to check that if you've missed any HCFs for those observations. There's no exact number that you should have. I do find that having three HCFs for each observation seems to cover your bases more often than not. Next, you should try and attempt to sort your observations by most to least important, as this lets you prioritize the time that you're spending on your HCFs. You also find that some assessments cover a lot of different domains, so those ones are good ones to pick when you're thinking about your tests as well. Now, if you have more than one functional problem, which is definitely realistic, no one ever just has one thing that they can't do, you should link each of your observations back to that specific problem that it's relevant for. So for example, you might have someone who's having difficulty walking upstairs, which we would consider a lower limb issue, but they also might have difficulty reaching up to hang out the washing, which is an upper limb issue. So if you see something happening at the ankle, that's going to be far more relevant and far more important for the lower limb issue than it is for the upper limb issue. By the same token, that if you see reduced shoulder flexion, that's probably not going to stop them from walking, but it is going to stop them from reaching up onto the washing line, and you would prioritize each of those like that. And finally, when you're setting your goals, it should always relate back to your functional problems. So basically, if you've got a goal that doesn't include the same words that your functional problem has, it's probably not a very specific goal. Can't think of any examples off the top of my head, but definitely once you've got your functional problem, come up with your goal. If the goal doesn't look identical to the functional problem, for the most part, using the same words and the same phrases, then probably rethink what your goal is. And as always, try and use the SMART acronym, as we definitely want to be measuring how successful our interventions are. So hopefully that helps. Fair bit to digest. To start with, doing it my way does take a little bit longer than you've probably been given in the tutorials, but as you get better, you'll get faster, and I find this way you won't miss anything, or you're less likely to miss anything. So hopefully that helps. You can leave a comment if you've got any questions, and I'll try my best to answer them. Thank you.